Hello, can you hear me? My name is Karen Eaton. I know a fair number of you in this room. I have sort of a dual role. I teach medical decision making. I do research in patient decision aids and patient decision making. And I oversee the doctoral and postdoctoral programs. So I've seen you in many capacities. So today I'm going to talk with you about our evidence-based decision aids in women's health. How many of you have heard of a decision aid? Yay, lots of people. Okay. So I probably don't need to put this definition up here. But the decision aid is not designed to make a decision for you, and it's not designed to replace a discussion with the provider. For a patient, it's really designed to help people become involved in decision making by providing information about options, by helping the person kind of work through the issues, clarify values. And as I mentioned, it's not designed to remove that visit with the provider. It's really to help you have good, fruitful discussion. So the decision aids I'm going to be showing screenshots from today are all designed using the International Patient Decision Aids Standard, and I'm part of this collaboration. And the purpose of this collaboration is to establish an internationally approved set of criteria to determine the quality of patient decision aids. So what does all this mean? This means we need to provide decision aids that have enough detail, that present things in an unbiased way and are understandable for patients, that help the patients work through the issues and clarify values, and provide some kind of feedback at the end or structured guidance. So I'm going to show you some screenshots from 3 of our aids. One is for domestic violence, one is for mammography for women in their 40s. How many of you heard the big news that broke on Tuesday? Okay, we'll talk about that a little bit today. And childbirth after cesarean. So the domestic violence decision aid is an aid to help women plan for safety. After pilot studying, we got an R01 and we deployed this in 4 states through the internet. And we've just begun producing our manuscripts with the results. The mammography decision aid is to help women in their 40s, first of all, find out if they're average risk, and then if they are average risk, to help them weigh the risks and benefits of starting mammography in their 40s or waiting until they're 50. Childbirth after cesarean, for the woman who delivers a baby by cesarean and is ready to have another child, she must decide whether she wants to schedule a repeat cesarean or will she try and have a vaginal delivery. All right. So in this talk, I'm going to show you some screenshots of the different ways we help patients assess their own risks, become informed, and then set priorities for the decision and how we provide feedback. So all of our aids have some kind of a secure login, and that way patients can return to them. But again, it's something they have access to, only they have access to. This is a screenshot from our domestic violence decision aid. The self-assessment in this one asks the women a series of 20 questions. Questions like, is there a gun in the house? Has he tried to choke you? Though the responses to those 20 questions have been validated in a tool, have been used in a tool that was validated against homicidal records to indicate how much danger the woman is in. So as we can see here, this woman scored a 19. She's in a level of danger somewhere between severe and extreme. And then they get appropriate feedback. So we met with advocates, providers, and patients to develop what that feedback should look like. Because sometimes when you see information like this, it might be scary. And how are you going to respond? So we had to make certain what we developed would appropriately engage the person. We also did a risk assessment for our breast cancer screening decision aid. We called it MammoPad because we deployed it on iPads and it was for mammography. We're still working on the name though, so that's what it is now. Because we deployed it on MammoPad, we couldn't just throw up 20 questions and have people go through with radio buttons and click them. So there had to be a series of questions, and these questions are nested. So these are questions about personal and family history. If you say yes, you have personal history of breast cancer or ovarian cancer, it would triage you to an appropriate message to see your provider and set up screening. If you indicated that a family member had breast cancer, Then it would ask you a series of questions to find out how many family members, how old were they, and that sort of thing. And these questions are all based on the BRST model. So, and the women responded well to these. So they used this tool up front before they had access to the actual aid. The clinics were really excited because it helped identify women they didn't know were above average risk. And in our study, about 10 to 15% of women who used our tool were discovered to be above average risk. So now I'm going to show you some screenshots of how we inform patients about their options and the evidence. So the first thing I'll talk about is what you heard Tuesday. So up until Tuesday, most women have been told, not all women, but most women have been told, start getting an annual mammogram when you turn 40. That's if you went to your gynecologist. If you went to your family medicine doctor who follows the U.S. Preventive Services Task Force, that doctor might say, wait till you're 50 and then go every other year. Okay, so you have your gynecologist saying start when you're 40, go every year. You have your family doctor saying, no, wait till you're 50 and go every other year. Wow, that's confusing. So what do women do? Then on Tuesday, the American Cancer Society released new recommendations moving this back to 45 for their recommendation, but encourage shared decision-making between 40 and 45. Both the U.S. Preventive Services Task Force and the American Cancer Society encourage shared decision-making for starting before age 50. So this tool helps women kind of understand the risks and benefits of whether to start screening earlier. And really, just to remind you, it's really a choice that these women are making while they're discussing these options with their providers. This is a shared decision-making opportunity. So what we did is we provided information about risk. In this pictograph that you see, 1 in 70 women, average risk women, between the ages of 40 and 49 will develop breast cancer over a 10-year time period. And we showed this same pictograph for women in their 50s. It was 2 out of 70. We also tried to convey that some forms of breast cancer are very aggressive, and some forms of breast cancer are not. So what we found is that we had to really test these graphics. So we had lots of conversations with women. We said, look at these graphics, tell us what you see in your own words. And the first time we developed this graphic, we were very pleased. We had this animation. We had the little pink figure moving all around. So we were trying to convey that it was 1 out of 70, but we don't know who the 1 out of 70 is. Until the third woman who used the tool, and she said, oh my gosh, as time passes, it's going to be me. It's like a ping pong ball popping all around. Wow, that wasn't what we meant. So we had to revise how we presented this. So now a pictograph shows like this, and then it fades away, and a question mark comes up. And the women seem to understand what that meant a little better. With this one, we originally had one woman. We had half of her body, one color. We showed organs affected. We showed a bigger tumor. On the other side, a little tumor, and nothing else affected. Again, we thought it was really clear till about the 5th woman used it, and she said, I had no idea breast cancer on the left side is way more aggressive than right. So back to the drawing board. We needed 2 separate figures. So we do a lot of working with patients and providers to make certain what we're presenting has face validity and is understandable and is written in plain language. This is another graphic that we tested with women. We went through a lot of iterations, as Michelle, who was on the team, can speak to. But in the end, we went with this graphic that shows, because it wasn't really feasible to show 1,000 pictographs, 1,000 figures up on a pictograph. So if we had 1,000 women, average risk, in their 40s, who have a mammogram today, 899 women would have normal results. Of those 899, there would be 1 cancer missed. There would be 101 women who would have abnormal results and need further imaging. Of those 101, 2 cancers would be found and 1 precancerous lesion would be found. And so the women did seem to follow this diagram. They did seem to be able to track what happens to those 1,000 women. So in addition to informing, doing a risk assessment and informing, we also want to help the patients process the information. weigh pros and cons of screening in the 40s versus not. And we did this in a variety of ways. We started off in our early prototype with 10 different attributes of what was important. However, look closely at what these are. Avoid false positive. Avoid false negative. Okay, when we started asking women what these things were, they had no idea. Even though we put what we thought were very clear definitions, it was still very complicated. And so we worked very hard to come up with plain language presentation. We also did away with 10 things. Most people cognitively don't process 10 things very well. And so we narrowed it down to 2 primary risks and 2 primary benefits. And this is actually 3 little screenshots. But we asked the women, what's most important to you? Please choose the one benefit that matters most to you in deciding whether to have mammograms on a regular basis in your 40s. Peace of mind of having a mammogram that shows no cancer or catching cancer early. It might mean simpler treatment, could mean reduced chance of dying. So those are they had to pick one of those 2. Then we asked them to think about the 2 harms and which one of those harms would be most important. One was extra tests and worry from false alarms, having a mammogram that finds something that really isn't cancer. We have 101 women who had to come back. Also, no improvement or length of quality of life, and unnecessary diagnosis. This was that overdiagnosis term. And they seemed to understand that pretty well. And then at the end, we asked them again to look at the one benefit and the one harm that was most important to them and pick one. For childbirth, our childbirth decision aid, we took a slightly different approach. All of our aids have some kind of underlying model, which the patients don't see, but we know that it's behind the interface. And we have a mathematical way to combine the responses that the patients enter in setting priorities. So in this one, remember, we're shifting gears to having a baby after you've had a cesarean. So the 4 main criteria that we learned from the literature and in interviewing women and providers were: avoid risk of future pregnancy, avoid injury to mother, avoid injury to baby, and have desired delivery experience. So the women did a series of pairwise comparisons, and I'm going to show you those in just a minute. And then we took those comparisons to figure out what the priority weights were. So this is an example comparison. Avoid injury to me versus avoid injury to baby. This woman has indicated avoiding injury to baby was 3 times more important than avoiding injury to herself. If you go back to this model, these are the priority weights that were computed out of that activity. We give this information to the women so that they see how they're prioritizing. Because just asking someone to do simple ranking doesn't necessarily convey how important a particular item. Maybe there's one driver that's really really pushing everything. In this case, avoid injury to baby. We took a similar approach for our domestic violence decision aid, thinking about your relationship, which of these 2 factors is more important to you. My concern for safety versus having resources. If she moves out, she may suddenly lose her health insurance, her house, ability to put food on the table. So these are really hard things to sort out, but we know in here she's doing that. She's thinking about those things. We then give feedback to the participants in a variety of ways. So for the pairwise comparisons, the feedback begins with just a simple bar chart. In this case, the woman was told that her child's well-being. If you had 100 pennies, 35 of those pennies would be in the child's well-being bucket. 25 would be in safety for herself. And once they see this feedback, they can go back and make changes. Once they see their danger level, they may want to go back and make changes. They have the opportunity to return and do that. We then take the information that they have entered into the decision aid and we give them a customized report. The customized report also provides some generic information. This is the general information about risk. But the second page is really, you can't see it, I apologize for the teeny tiny font, but it addresses what's really most important to the women. It states out what their concerns are about mammograms. If they have questions, we have a pick menu of questions. They can also type in their own question. So it prepares them for that conversation with a provider when they go in. Now, this report, they can email to themselves. They can email it to a provider. We're currently working with some clinics to try to integrate this into MyChart so that some kind of a snapshot or small version of this would be available for the provider to prepare, again, for that conversation. So as I just indicated, everybody, all of the participants in all 3 studies got some kind of report. And at the end of the day, when we measured the decision-making process before and after using the tools, all 3 of the studies showed improvement. The women felt more informed, had more clear priorities around health decision, felt more supported, and reported overall less conflict about the decision. So these studies suggest that evidence-based decision aids in women's health improve the decision-making process after only 1 session with the aid. However, our domestic violence one, they got to use it multiple times during the year, and we are currently summarizing those results. I don't have those today, but those are coming. Some of the new work we're doing is not just for the person who is a primary decision maker. It's also for the person who might be helping that friend or family member. In this example, we are deploying a decision aid at college settings, and if a woman has been assaulted, there's often a friend who's there walking beside her and trying to help. But the friend doesn't feel equipped. So this particular aid has a triage point. If you're the friend or the survivor, it kind of sends you off into the 2 different directions, and it gives you resources as a friend on how you can help, and it gives different resources, somewhat different resources for the survivor. So that's sort of new work. There's not much work done in this area. Yeah, I know I'm running out of time. So I will just jump quickly to, these are the funders and sponsors for this work. NIH has sponsored in a variety of ways through my K-12 and also through the NLM Fellowship. We also have a large R01 through the National Institute of Mental Health. And we've received some foundation funding. And the Oregon Rural Practice Research Network has been very active in deploying our mammography decision aid. And I think these slides are going to be available to you if you want to read more about them. And I think we have like 3 minutes left or 4 minutes left. So, questions? Sure.
So on the
Yep.
So on the slide you had of the decision aid for domestic abuse, it sounded like you were providing a pretty strong suggestion for the user to pursue a police report or consult some sort of authority in some way.
We actually were careful not to tell them, we were careful to say, here are the resources to do that. I'm trying to see, is that within the danger level slide or from? Yeah, right here. Yeah, so the feedback is this person was at a fairly high level, so we were encouraging them to seek resources, whether it's an advocate, it's a lawyer or police. They don't always go first to the police. Sometimes they'll go to a support center. But if they reach that level of danger, they need to be seeking some kind of resource. Now, I did spend a day watching the restraining order process and learning about that. The legal process is not easy, and it's challenging. And so not all the women will pursue that, but the advocate can help explain to them that process. And our aid, if you click on the resources, tells you a little bit about that process.
Okay. I guess my question was, a hypothetical example. We say it's critical someone goes to the police, in fear of her own safety. If she does that, and then her abusive partner finds out about it and becomes very violent towards her, is there any risk of being the target of litigation, or do you guys hold any liability for anything that can come of making these suggestions?
That's a good question. We have had these tools evaluated for that. We also use extreme care in counseling the women about how to clear their cache, how to remove history, how to use the computer in a safe location. So we've had to take extra precautions for that reason, because we know there's some stalking behavior. And the abuser might be looking on the computer to see, well, where is, my significant been lately? So we provide strong feedback with that. We had also advocates in each of the states who were personally able to get on the phone and talk with the women and get them into the right centers as needed. It's a good question. We don't tell them, we were careful never to tell them what to do. What these aides do really say, here are the resources. This is an awareness. Be aware that you are in danger. When we presented this to a group of judges from family court, they wanted to see the reports. For the women who were in our study, I said, I can't provide that. It's confidential. If the woman chooses to provide that, that's up to her. But we can't provide that for you. It's really up to her. Good question.